This video is going to cover a standard CHROME guided smile surgery. We're going to cover the entire process of performing the surgery. The doctor who performed it is Dr. James Hamill. He is in Ireland. He owns a company called Chorus 3D, who is our partner. He has performed nearly 200 surgeries and has developed a keen awareness of the process of CHROME and also the efficiency of CHROME, and has performed all these surgeries in under 2 hours from start to finish. He was kind enough to document a full surgery. So we're going to do a voiceover and talk our way through it. As with every CHROME surgery, the first step is to try in the pin guide. The pin guide is what rests on the tissue or teeth and sets the stage for the full surgery, because it will deliver the metal fixation base, which is anchored and receives the stackable componentry. So the first step is to take the pin guide, seat it, and do an inspection. And at this point, you would inspect to make sure, you can see he has 2 fingers here. He's going to inspect to make sure that there is no rocking, that there's a full seat, and that the windows in the pin guide will allow the teeth underneath to show how intimate they are with the pin guide. So you can test to make sure there's a full seating, and there will also be a window on the tissue area. Now, the more tissue under the pin guide, the more chance of anesthetized tissue that is swollen holding the pin guide up. So in a case like this, where there's 3/4 of the arch is a tissue supported guide, you want to be careful that inflamed tissue has a chance to dissipate and to not be swollen. Now, you can use a pin guide to put some pressure on the tissue to reduce the swelling, or you can wait, 5 minutes or so after injections. So he's checking to make sure there's no wobble, and then doctor will make an incision. So let's just presume that the pin guide had a nice solid seat and it's time to progress. Now, in a case like this is nice to be able to show this. This is partially, mostly edentulous, so we can see the different types of reflection. On an edentulous case, you will make a crestal incision and lay the flap forward, and you'll lay the flap all the way up to the area above where the metal is going to be, the pin guide and the metal assemble. And then around teeth, this is just degloved around the teeth, and then crestal here, and then degloved around these teeth here. So you're kind of seeing both methods of laying a flap. Crestal incision all the way back. How far back do you go? When you insert the pin guide, or in the metal too, if it will fit, you'll see the metal will come all the way around back here. The metal goes to 10 millimeters beyond the terminal implant. 10 millimeters beyond the center of the terminal implant. That's our rule. So lay the flap back to that area, to the end of the fixation base. And that will help with ensuring the tissue is out of the way so that the bone reduction can be at the end of the metal. So now, using instruments, elevators, not elevators, just tissue retraction tools. Right here, almost a full reflection. Take a little bit more. And you could try the pin guide of the metal in at this time to see if you need more reflection. You can kind of see how much reflection here. The nice thing about CHROME is that there is mostly labial reflection, not lingual. The lingual will be just to the level of bone reduction. It is not completely degloved on the lingual to have to accept any kind of surgical guide that has a lingual wrap. This is only a labial bow with the metal. The metal and let me go back here a little bit. The pin guide and the metal are now assembled using the CHROME locks that are these blue plungers. Be sure when you assemble this that the pin guide and the fixation base are intimate, then push the blue plungers in. The reason I say that is because you don't want to have it not fully engaged and then try to force a pin in and break the little loops on the pin guide. All right, with them assembled, the pin guide is now inserted all the way down to a full seat, just like we practiced before making the flap. And now it should seat on the teeth. It should seat somewhere on the palate and the lingual part of the ridge. Unfortunately, this patient has some teeth, so it's easy to make a very positive confirmation that it's seated. We're going to go through the pinning process. So while the nurse, well, in Europe, they're referred to as nurses. Here, they're assistants. With surgical tech or assistant, holds the pin guide down firmly through the entire process. That is very important. You don't want to let up on the pin guide at all during the pinning process. So hold it firmly, occlusally, so that it doesn't move. And then, in this case, this is a green. So it's a short pin and a short drill combination. And what the doctor will do, this drill is going to, this is the maxilla. So the drill is only going to go about 7/8 of the way in, about this far. Okay, so the drill should stop short of the metal. And the reason is, in the maxilla, the bone's a little bit soft. And so therefore, we want to push a pin in, and then we'll use a surgical mallet to push it to full depth. You can see these pins are up a little bit. All the pins are in now, but let's talk about that a little bit further. While the assistant is holding down the pin guide, you'll place a drill 7/8 to depth, place a pin, move to the next site, repeat, drill, and then pin. Do that for all 4 sites. Then come back with a surgical mallet and the mirror handle so that you can tap in the pins to full depth. Now be sure that when you're tapping in the pins that you are not over tapping and moving the metal. That'll be hard to do because you have 4 pins holding it in a position with 4 different trajectories. But tap each pin down until they touch the metal. You'll hear the sound as it changes as soon as you hit the metal. Okay, so tap all 4 pins in, and then the assistant can let go of the pin guide. Then the pin guide is removed. I think this is an actual instrument that doctor uses for tapping, but most of the time, if you take the mirror off of your normal standard intraoral mirror, then you can use the handle, the shaft of the handle, to tap in. All right, so tap, tap. Sometimes it can be a little aggressive. This is if your patient is awake, you'll want to talk about this before it happens, so it's not too shocking. And also, normally this is a 2-person job, one holding the handle and one tapping, but Dr. Hamill has a lot of experience. So you tap them until they're flush. And if you need to be a little bit aggressive, that's okay. Tap, 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 tap until they're down. Then tweezers or some tool like that, use that to unclip the blue locks. And then the pin guide will come out, and that will expose the teeth and the bone to be reduced in here, and the doctor is still tapping these in a little bit further. This is such an important part of the CHROME process, and it's worth it to just slow down and take the time to make sure that the fixation base, the metal, is in the proper position and that the pins are down. This is key to making sure that the occlusion is right, that the bone reduction is right, the implants are in the right position. Everything is based on that fixation base being in the proper position. And that is because our fixation base is totally pin supported, right? It is not bone supported. And you'll see that as we go through the process here. The pin guide, he's just taken obviously this is on a computer screen, but the fixation base is floating. It never touches bone. That's part of the patented process. So the pin trajectory is what holds the metal in place, which is really a key to this whole process, because it's nearly impossible to deliver a metal guide into undercut, any guide into undercut. So that's why it's floating for draw. Okay, next step, fixation base is in, pin guide comes off. You saw an extraction there. The teeth are now extracted. Then doctor will take a very aggressive burr and level the bone down to the height of the fixation base. So this fixation base serves a couple of purposes. One is to set the foundation for all the subsequent guides, the carrier guide, the osteotomy guide, the teeth. And the other is that it's a bone leveling guide. All right, so that you follow from the metal all the way across flat with a burr or other tools, piezo, surgical saw, surgical disc, rangiers, many different options to level the bone. And what the doctor is doing here is just laying the minimal lingual flap. All right, so this should go down just a little bit beyond the bone reduction. And then once it is flapped, then doctor will stitch this together to keep it out of the way. There you go. There's a stitch right there. That just helps, hold the tissue back from the area of, where the burr is going to be grinding the bone. All right, next step, bone reduction. Now, in this case, he opted to use a piezo, cut a straight line, and you notice the piezo is resting right against the metal. Okay, so this is somewhat eyeballing, standing over the patient, looking down the metal and just visualizing the flat plane of the bone following the fixation base. So he's going to use using a combination of a couple of different tools. All right, this part is also critical. Often with first-timers or early users of CHROME or of doing guided bone reduction without a lingual bow, often the bone reduction is incomplete or it is not as perfect. Often you see this is not a pineapple shape, but a pointed tip. And so that means that the lingual bone is going to kind of follow the burr. Right? So you have to just be careful to bury a little bit deeper and also adjust the lingual bone. This is almost always the hang up. The lingual bone back here in the posterior, right here in the incisive canal. So just visualize it, even ask an assistant to say, hey, well, where do you see bone that's too high? And the reason is because if the bone is not reduced enough, then the carrier guide won't seat, and you'll also may not have enough space for tissue and prosthetic, because we have developed the prosthetic to be 2.5 to 3 millimeters above the bone so that we have space for tissue. At this point, once the bone reduction is complete, this carrier guide should seat passively in the mouth. Do not force this in. At this point in the process, we are trying in the carrier guide to make sure that the bone is reduced enough, and then at this point we try the bite before the patient's jaw is too tired. If it is rocking or it won't passively seat, then it's either tissue in the way that you need to remove, or there is still bone. Now there could be bone inside the locks, so we'll look inside the locks as well. But if they're clean, then it's either tissue or bone, and go back and address this before moving on, adjusting, manipulating, moving tissue, whatever it needs to take. And then once this clips in, then take the prosthesis and seat it on the pegs and close the patient. And we do this so that we can test the bite now. This is just an option. But it's really nice to know where you're going to be in 20 minutes from now or an hour from now when you have all the implants and abutments in, how the bite's going to be, just for peace of mind. Teeth come out, the prosthetic comes out, the carrier guide comes out, and then what we're going to do now is drill for sites, drill for implants. And this osteotomy guide, this patient's going to have all angled implants. How do we know that? Because there are nubs here that indicate the rotation of the multi-unit abutment. And on cases now we have 6 nubs instead of 2. 6 so that you can see this in any direction. So this case is a few months old from an old system, so you'll see 6. And then if it's that's an angled, and if it's a straight site, there won't be any nubs at all, because you won't have to do any indexing to make sure that the implant's in the right rotation for angled of multi-unit abutments. All right, you clip in the osteotomy guide, make sure that it's down, good, no wobble, good to go, and then go through the process of drilling the sites. This is a Neodent case. This is the Neodent keyed kit, starting with a 2.0 and going to drill through the drill sequence. And we will not go through this whole process, but it is helpful to just discuss this topic. You can see that the visualization of the case. You can see your drills going into the bone. You can irrigate easily. Now this has integrated irrigation, but often we see in surgery it's a syringed irrigation, and you can put the tip right here and you can put it right on the bone. You're not dropping it down a plastic cylinder or trying to get it down in a plastic guide with no accessibility or visibility. All right, so you have full visualization. You can watch the drills go in to the bone. You can confirm they're in the right position, and you can irrigate. With this system, fortunately, the implants can be placed through the guide. The driver here is the same driver the same driver size as the drills. So carefully place the implant. Now here's a key. This is something that that James teaches in detail, and that is the timing of the implant, the depth and timing at the same time. And this is a very, very good tip because it's so critical to get torque and not have to mess around with implants, turning them in, turning them out, etc., to get the right rotation. So at this point, you put the implant at normal speed, just like you normally would, and when you get really close to hubbing out, then you slow down and you time it so that the hub is going to meet and that the notch is going to line up. So in this case, with this neodent, this little circle needs to line up with one of the nubs. Now you can see this is a 6-nub case, so he put a different video in here just to show this modern osteotomy guide. Rotate a nub until it hits, and then stop. And then visually you can see if your implant's in the right depth. Now if you need to make it shallower or deeper, so be it. Make it, turn the implant until you're happy with the position. But whenever possible, turn and stop and be done with it. Move on to the next one. Let's see, he's just going to turn on to the next one. Okay, and the dot, and then stop. And you saw him stop right on that nub. Okay, angled sights, always profile. That has to be part of the routine because on angled sights, part of the implant is subcrestal. It has to be exposed, otherwise the multi-unit abutment will not seat. So always profile. Try to find a profile kit that comes with your implant. That's the best way to do it. Might have to buy a third-party one, but always have to profile. Otherwise, you'll struggle with multi-unit abutments, and they will not seat. And then you'll have to profile later. And a profiling kit is better than just doing it with a burr for just quick, predictable consistency. The implants are in. All of those sites have been profiled. The carrier guide is in. The carrier guide has a little black mark here. If the implant is angled, there's a little notch and a black mark. This will indicate where the abutment screw will enter the abutment. The abutment screw, the driver, everything will go right through this black notch into the abutment. That is the trajectory of the implant and the screw and the driver. Carrier guide is seated. Multi-unit abutments are placed. Leave the handles in at this point. Leave them all in because then you can look up at the surgery mat and you can ensure that the trajectory of the temp cylinder, which is the same as the handle, follows the surgery mat so that you can ensure that the temp cylinders are maybe parallel, but at least they mimic the surgery mat. So you'll see on the far right image on the mat, there are yellow cylinders protruding down in the photo. That is the trajectory of the temp cylinders. Okay, so they're right here. He's discussing how the screw goes through how the abutment screw right here goes right through the notch. This one's here. This one's here. It's very, very important that that is followed because if the implant is off rotation, then that screw is not going to be right where the notch is, and then the temp cylinder is going to be crooked. It's going to be pointing in the wrong direction, and then you're going to have to either rotate the implant or you're going to have to make a big unnecessary adjustment to the prosthesis so the temp cylinder will seat. The handles are in. The handles all were properly placed. The doctor moved on from there. So the abutments were in the right rotation, and then the handles were removed. The temp cylinders, go back here just a little bit, all the temp cylinders are then screwed down to the multi-unit abutments. And during this, because there's a little bit of a angulation issue with this one, I'm not saying it's an issue that might be exactly as it's planned, but he is going to try in the prosthesis and make sure he has some passivity. So he's just kind of giving it a test, okay, and checking it out. All right, now all the cylinders are in. Prosthesis comes out. These little gaskets now sleeve over the temp cylinders to block out for the pickup material. The prosthesis goes in, and then the little blue plugs are placed for blocking out the temp cylinders. And then we use our standard Stellar DC acrylic. This is a dual cure material. right here, Stellar DC acrylic, a dual cure resin. And this, we recommend this material for all of our chrome surgeries. It comes in pink, it comes in white, and it's wonderful because it's a dual cure, right? And that is important. You don't want to have to wait 2 minutes for a self-cure. You want to hit it with a light and be fully cured in 20 seconds, all right? So you can see here that what the doctor did was backfilled the resin inside, even all the way up around the blue, so that now he has a screw channel. You don't have to develop one later. So he filled the hole and then came back and hit it with a light and tacked it in. Now at this point, you want to put resin on every single hole and then come back with a light. Don't do one at a time, because if you do one at a time, then a tendency is to let go and think that that now you have the prosthesis tacked in. But the fact is, if you just tack in one and then you come back and tack the others and you're not holding it down, you've introduced tension on this one. Okay, so pick them all up at the same time. Then the plugs come out. Okay, keep light curing, never hurts. You can do a full light cure, full curing of the material. And then prosthesis comes out. It'll come out with the gaskets. And then that prosthesis goes back into the lab to be converted. And just as a reminder, this is standard chrome. This is not our C2F small hole extraoral conversion. This is not SmileLock. This is standard chrome with standard holes. So that means that this prosthesis, you can see a little pink here on the lingual. This is the take-home prosthesis. This is the one the patient's going to wear home today. Once that's taken back in the lab and it's adjusted, another set of temp cylinders goes in, and then we pick up the rapid appliance. Now you'll notice, again, this video is months old, but we add pink now to our rapid appliances. This is the backup prosthesis. This is the one that will be used, that the patient will wear when the other prosthesis comes to the laboratory for final restoration. But we added pink to this now, so it's more aesthetic, so if the patient needs to wear it for any reason, then it looks nice. All right, so now you pick up the second prosthetic. There's 2 pickups, one the patient wears home, and then one that's used for records later. And we're gonna, let me hit pause here. We're gonna talk about that for a second. Patient wears home a beautiful prosthesis. They wear it for 5 months. And then in 5 months, when they come in, if that prosthesis is intact, and what I mean is if it hasn't been worn down too much with adjustment, the bite's good, the patient enjoys it, that can be used as the record to go to final. If the patient has worn it down quite a bit, or if for any reason the rapid appliance is not going to be sent home worn by the patient, then you can use that. You can use the take-home prosthesis for the records. Otherwise, the rapid appliance is used for the records. And we have videos on the restorative protocol of that. But that is why we pick up 2, so the patient doesn't have to go without a prosthesis during the final stages. The rapid appliance has now been picked up. The carrier guide is removed, and the suturing caps are placed on the multi-unit abutments. Okay, the pins are removed. The fixation base comes out. If there's any bone grafting to be completed, that commences, and then the patient is sutured. Meanwhile, back in the laboratory, the prosthesis is being converted. Once the prosthesis is converted, meaning the titanium cylinders have been cut down if needed, the prosthesis, any holes or voids have been filled, it is delivered. And this video is just going to cover the surgical part. So there are videos that show, delivery of the prosthesis, but that is how an efficient surgery is performed. Hope you enjoyed the video. We would love to come chairside for your first, your second, or your third to help with any of this process, with the tips and tricks, and help you with the conversion and teach the team how to do a conversion.